Good afternoon, everyone. Some of you know me, but those who don't, my name is Namrata, and I'm a Commonwealth Rutherford Fellow here, working on smallpox eradication in Goa in the 1960s. A very warm welcome to all of you to this 108th Global Health Histories Seminar. The Global Health Histories Seminar series has been based on the idea that the history of health, especially in the last 60 years, can help global public health community respond to present-day challenges. The seminar series was launched in 2004, and since then we've had more than 100 seminars, and it is envisaged as a way of bringing together academics, policymakers, health service professionals, and the public at large, and also to enable a dialogue between historians, most of us here are historians, and public health professionals. Just to let you know that today's seminar, like all other seminar series, is being recorded, and it will be available online in a few days. I'm very pleased that we have today Dr. Niels Brimnes, and Dr. Shiva Murugasampillay, and I will introduce both our speakers in a moment. Dr. Niels Brimnes is Associate Professor and Head of Department, the Department of History and Classical Studies at Aarhus University. He's researching the history of global public health and has published extensively on the history of TB control in India in journals, in very prestigious journals like Bulletin of the History of Medicine and Social Science and Medicine. He has a chapter in the book on TB that our center has published, and some of the books are here to my left, and they're free for you to take. In 2016, Dr. Brimnes published the monograph Languished Hopes, Tuberculosis, the State and International Assistance in 20th Century India. Today he'll be speaking on, as all of you can see, the rise and fall of India's National Tuberculosis Programme, 1960 to 1993. Dr. Shiva Murugasampillay is with the Global Public Health, which is based in Geneva, and he was formerly Senior Advisor to the Global Malaria Programme at WHO. His presentation is titled, Fighting Diseases versus Health for All. Dr. Brimnes will speak first, and then Dr. Murugasampillay. So I invite Dr. Brimnes.
Thank you very much. Thank you for the opportunity to participate in this prestigious lecture series. Thank you, Sanjoy, for inviting me to do this here in York. The title of my presentation is The Rise and Fall of India's National Tuberculosis Programme, 1960 to 1993. And what I'm trying to do is I'm trying to narrate a very important episode of the history of global TB control. Global TB control that is essentially, after World War II, a history of the control of TB outside industrialized societies in Europe and Northern America. So let me start by taking you back to... No, we use this one. There it is. 16 September 1960, to Bangalore, to a manor donated generously by the former Maharaja of Mysore to the Indian government to establish a National Tuberculosis Institute. There was an atmosphere of enthusiasm and optimism in the air on that day, and a lot of people were gathered. It was health bureaucrats, it was politicians. Jawaharlal Nehru was there to see the inauguration. And one of the main persons in the history of TB control in 20th century India, the Indian doctor P.V. Benjamin, spoke, and he said, today, the 16th September 1960 is a memorable day in the history of anti-TB movement. The institute is a departure from orthodox procedures, and a totally new idea is going to take shape. Another important person at that time, WHO senior medical officer, Halfdan Mahler, who had helped creating the ideas or setting up the ideas behind this institute, he also spoke, and he said that to him this new institute was a sign that India had decided to tackle tuberculosis by one comprehensive plan, by a considerate and decisive course of action. So something new was going to happen. That was clear. And that something new was going to be different from what had gone before. And I think what had gone before was the approach to TB control in India in the 1950s, which consisted mainly of two elements. Well, first of all, there was an extensive involvement from WHO and UNICEF in what happened in TB control in India in the 1950s. I think that is true for the 1960s as well, so that didn't change. But what changed, what was supposed to change was that one of the major efforts carried out in India was mass BCG vaccination against tuberculosis. The mass BCG vaccination campaign, as it was carried out in India through the 1950s, was seen as the largest vaccination effort ever undertaken in the world at that time. It was a vertical campaign. It was vaccination teams that went out to the villages and they vaccinated and left and went to the next village. The other thing that happened in India in the 1950s was the trials with domiciliary chemotherapy. Newly discovered or invented antibiotic drugs became available from the late 1940s. It was streptomycin, it was isoniazid, and it was PAS mainly, at least for my story. And important research was conducted in Madras, in South India, now Chennai, that proved that it was possible to treat TB patients with these drugs without bringing them to the hospital, because that had been the approach ever since these drugs were first tried out in European, North American countries, was to hospitalize people for up to 12 months. But what happened here was that research carried out in Madras did show that you could have the same results with these drugs, even if the TB patients, who would often be poor, would often be a agricultural laborer or a slum dweller in one of the major cities, he or she could actually go home, stay at home and take the medicine for 12 months and get the same results from it. But now, the new era in TB control in India was supposed to take place. It was dubbed the community approach. And here it is described by P.V. Benjamin in a publication from 1961, where he wrote, till recently, the generally accepted methods of tuberculosis control were mainly confined to a clinical approach. The new approach, now being worked out, is meant to tackle the problem on a community basis, where the preventive and social aspects will have a prominent place. So this was the ideas that were in the air in Bangalore in 1960, that this was the new community approach that was different from the old, more clinical and more vertical approach of the 1950s. And this is the National Tuberculosis Institute. This is the 5 sections that the institute had. It had a control section which was in charge of developing the National Tuberculosis Programme for India, designing an appropriate way of trying to control TB in India. And what I probably should say here is that the estimate was, no one knew how many TB patients that were in India at this time, but the best estimate would say that there would be about 500,000 deaths from TB in India around 1950, and that there would be 2.5 open infective, what we also call sputum positive cases of TB. So it was a lot of people. And until this idea of domiciliary chemotherapy, where you treated the patients at home, until that became established, you had about 6,000 hospital beds assigned to TB patients. So you compare 6,000 beds with 2.5 million cases that urgently needed treatment, you can see the challenge. So that was the challenge of the control section, to develop a feasible, realistic control program for India. Epidemiological section had to monitor the epidemiology of TB. The bacteriological section did laboratory services. Statistical sections surprisingly processed all the data that came out of the research that was conducted at NTI. And then there was, importantly, a sociological section. And that was uncommon in 1960 to have a sociological section into a disease control center. And 40 years later, when the NTI celebrated its 40th birthday, they looked back at this sociological section and wrote in the publication that came out to commemorate the 40 years of NTI, that this was the first time that social sciences was consciously included as hard evidence, and people's voices were placed on par with science, technology, and administration. So you see here at least the ambition of the NTI to take the patient perspective. When did the National Tuberculosis Institute, when did it then come up with a program? I would say, and most people would agree with me, I mean, you can argue when exactly was the Indian National TB Programme born, but I would say it was born in 1962. Because in 1962, the government of India circulated a document written in the NTI with recommendations, as it said, recommendations for a district tuberculosis program. So the government of India sanctioned the model that was described in that document, and that was, as I said, from the beginning of 1962. Also in 1962, a Belgian WHO medical officer attached to the NTI wrote an article in the Indian Journal of Tuberculosis, outline of a district tuberculosis program, which was more or less identical, or said the same thing as this policy paper that was distributed the same year. So this, I think, you could say, this is the start of the Indian National TB Program. And as you can see, it was envisioned as a lot of district programs. So the district programs were sort of the core of the National TB Program. Here I have tried to set up the infrastructure of the National TB Program, and it is, of course, at the top, you have the NTI in Bangalore. In the NTI, the idea was that research should be carried on, and key personnel should be trained. Personnel that could then go out, take up superior positions in the program, and then also train more ordinary personnel in the program. State centers, each of the Indian states, so be between 15 and 20 of them at this time, would then be supposed to supervise the program in the state, and also to do the more routine training of these TB workers. That was supposed to happen in the state centers. I don't think it ever happened, but that was the idea. And then the key thing, the key element in this program was the district tuberculosis centers. Each district in India having perhaps 1 million inhabitants. There would be several hundred districts in India. The number changes over time. And in that district tuberculosis center, there would be facilities for diagnosing TB. And you could diagnose TB in 2 ways, either looking at sputum through a microscope, that's called microscopy, or using an X-ray machine. And they were supposed to be there in each of India's districts. The vertical BCG vaccination campaign was also supposed to be integrated into this program. So the idea was to sort of to take the BCG vaccination team and base them at this district tuberculosis center, so that they could also work together with the other TB people in that center. And the DTC, as we can call it, the District Tuberculosis Center, was simply seen as the basic operational unit of the National TB Program. But below that, because of course one center in a district with 1 million or 1.5 million inhabitants and bad roads and all that wouldn't help. So below that you would have the peripheral health institutions, which would be the institutions where the Indian population would meet the health system. And the peripheral health institutions would not be specific TB institutions. They would be part of the general health services. So that was the point where you can say the special structure for TB control was meeting the general health services in India. So the idea was that at any of these peripheral health institutions, Indians could go and get the simple form of diagnosis, that is the microscopy. And they could, if they were a complicated case, they could then be referred to the district center for further investigation. That was the idea behind this NTP that was designed in 1962. I'll now try to line up the principles behind the National Tuberculosis Program, and the first interesting principle was that it was going to be based on what you can call passive case finding, or self-reporting patients. In 1961, in a district near Bangalore, people from the NTI carried out a research that was supposed to find out what is the best and most cost-efficient way of diagnosing TB patients. And what they did was that they distinguished between the mass campaign approach, we could also call that active case finding, where typically in connection with the BCG mass vaccination campaign, they would go out and not only ask the young people, those who were going to be vaccinated against TB, but also the elderly people to come forward and if they had a cough, if they were spitting blood, if they had a night fever over a long time, they could then be referred for further diagnosis. That would be active case finding. And you could then do active case finding either using X-ray or using the microscopy. And passive case finding was simply to say, no, we let people know that you have this TB diagnostic facility in the area, that you have it at the peripheral health institution, and we will let people come to us. We will not actively go out and seek them. And again, you would then say, are we going to use X-rays or are we going to use microscopes to diagnose TB patients? And they decided, based on this research that they did, that the best and also, fortunately enough, the cheapest way of diagnosing, or the most cost-efficient way of diagnosing TB patients would, under field conditions, would be passive case finding using sputum microscopy. So that was the first principle. We are not going to actively find the patients. We are going to let the patients come to us. It was based on the assumption, as P.O. wrote in that article I referred to earlier, that the philosophy of treatment was based on the knowledge that as much as a third of the existing patients are actually taking action on their own initiative, and that another third of the existing caseload would do so as soon as means of diagnosis are made available to them. So we know that a third of the patients will come on their own initiative. We know that by letting the people know that there's a possibility for diagnosis in the area, another third will come, and the last third, well, we don't have drugs, we don't have resources to treat them anyway, so we'll leave them. Stig Andersen, another medical officer from the WHO, wrote in 1963 that the NTP represented the basic philosophy that it is the first obligation of a tuberculosis program to take care of those cases which are now standing at the very doorstep of the health services seeking assistance. So let's deal with the patients that are coming on their own initiative. That was the philosophy. Drugs, of course, were supposed to be free. The ideal treatment that the Indian authorities, that the NTI decided on, was the cheapest drug against TB called isoniazid, and then in combination with a patent and therefore much more expensive drug called PAS. In reality, INH was given as the only drug very often. Because PAS was so much more expensive. This is a calculation made by the people in the NTI in 1961, just before they designed the program. And they said, if we're giving isoniazid or INH alone, we can, in a year, we can reduce the caseload of TB by 20%. If we add the more expensive drug, PAS, we can reduce the caseload by another 10%, 30%. The cost for dispensing INH alone would be 20,000 rupees in a year. If we add PAS, the cost would be 11 times as much. The problem with doing only one drug is the development of drug resistance. Because you would get a full development of drug resistance by applying only INH. So if you add PAS, you would have only 20% of that level of drug resistance. So you could reduce the drug resistance by 4/5, but at a cost that was 11 times higher. So what was decided was, in the circular letter that I was referring to earlier that sort of started the National TB program, was that it should be a definite policy. It was written in that letter, or in that circular, it should be a definite policy to treat all cases who are infectious, that is sputum positive, with 2 drugs. But then the paper immediately added, in the absence of 2 drugs, isoniazid alone may be given. And that is, I think, an indication that people knew that it would be very, very difficult to offer combination treatment to all the TB patients in India. Here's another quote to the same effect. It's from a medical officer 2 years later, James O'Rourke, who wrote in a report to WHO headquarters that nobody would deny that 2 drugs are better than 1, and that double drug therapy should be offered if possible for the infectious cases. But the use of streptomycin in rural areas may be disappointing. The problem with streptomycin was also that it had to be injected, so it was more complicated. PAS is expensive, as I have, and scarce, as I have explained, and tiacitazone, a new drug that was coming after the 3 initial drugs, may give rise to annoying side effects, so that the provision of a suitable second drug for all infectious patients in the immediate future may not be easily achieved. In these circumstances, there is still a case for using single drugs, even for infectious patients, and there's every justification for confining double drug to infectious persons wherever there's a scarcity. So what we are seeing here is we're seeing a program that cannot afford the good double drug or combination treatment. This is I'll get back to that. Another principle after the 3 drugs is that the patients should administer those drugs themselves. They should go to the peripheral health institution or to the district tuberculosis center if they live near that, and collect their drugs, I think, every 2 weeks or every month. And then they should make sure that they took these antibiotic drugs every day for 12 months. I think you can imagine that that was a little bit difficult. It was difficult, 1, because some of the drugs could be unpleasant to take. You had to go there with regular intervals to collect the drugs. And also, when you're on an antibiotic cure, you know that after 4 or 6 weeks, you start feeling better. Your symptoms disappear. So why should you continue to take the drugs for another 9 or 10 months? And especially, I think, if you are an illiterate Indian villager to whom it can be difficult to explain the principles of modern medicine. So this was a patient regularity. How to ensure that these patients could actually take the drugs was a major challenge of this program. Wallace Fox, the British doctor who headed the trials in the Madras Tuberculosis Chemotherapy Center, the TCC, in 1958, says that in essence, in order to make a patient take medicine regularly, morning and night for a year, it is necessary to establish a new pattern of behavior, and this many of our patients find difficult. I think, even if it's slightly patronizing, I think that it does point to a real problem in the program, and that is how to ensure patient regularity. The last principle, which I will not talk a lot about here, is that BCG should be integrated. The vertical mass vaccination campaign should be dissolved, and BCG vaccination should be done as a regular activity as part of the work in the district TB center. So, the program, which was launched, quickly ran into problems. The first problem is that you can see how, on this slide, how the expansion of the program slowed down. In 1961, the first 2 district programs were established. 2 years later, you had a total of 28 district programs working and functioning and being recognized as working district programs by the NTI. The top of the expansion of the program was, I think, 1966, when 42 programs was actually added to the total. That is the year I haven't taken. It's between the years that I've shown on the slide. But after that, expansion starts to go down. And if you look around 1980, there would still be 20% of the districts in India that did not have a district program. So out of approximately 400 districts, there would be only 320 with a program. And if you look at how many of the peripheral health institutions that were actually and in reality working together with the district center, the estimate was that then the National TB Programme, 20 years after its establishment, still only covered 50% of India. Because many of the peripheral health institutions simply did not do TB work. Another problem was the quality of the staff. Nagpur, one of the high-ranking officers in the NTI, wrote in 1968 with some sort of an air of despair. The quality of the deputed staff that was sent to NTI for training is sometimes so poor that it suggests indifferent interest of the selectors in the NTP. In fact, it is even alleged that some persons are deputed to the NTI as a measure of punishment for some false omission or commission on their part. I mean, the problem that we know that public health work can sometimes be seen as less prestigious as other kind of medical work. So people having a degree in medicine or working with medicine would rather do some other work than this more routine-based work. And at NTI, they complained about the quality of the people that were sent to them. Case finding. A well-working national TB program should, of course, be able to find a satisfactory number of patients. And in 1967, it was decided, again after people at the NTI had done some research, that a realistic and satisfactory level of case finding in an average district in India would be 400 patients per quarter, I think. I think these are quarterly figures. So 400 patients every 3 months. That was what a district program that was working well should be able to do on average. And as you can see from the reports sent from the districts couldn't live up to that target. It was between 30 and 40% in the years in the late 1970s. So case finding was a problem. The National TB program did not find as many cases as it was supposed to. Rather, less than half of the number of cases that was expected from the bureaucrats and the planners in the NTI. Drug supply, as I've already indicated, was a problem. In 1962, the year that the program started, there was a shortage of PAS. It was difficult to get. In 1964, the government of India stepped in to secure a sufficient supply of drugs. Until in the first 2 years of the program, the idea was that the Indian states should supply the drugs. And that's because in India, health was a state subject. It was not a subject of the central government because India has this federal structure like the United States. So health was sort of taken care of by the Indian states. Therefore, the Indian states were responsible for getting TB drugs out into the TB program. But after 2 years, the government of India steps in order to secure and put resources into getting these drugs. 1965, the Indian government actually had to ask UNICEF to supply isoniazid because they couldn't produce or import enough isoniazid in 1965. In 1968, there was again a shortage of isoniazids and also of other TB drugs, and again in 1969. So the thing is that very quickly a steady supply of drugs became a problem. Funding. It's very difficult to determine how much funds were actually put into the National TB program because it was supposed to be integrated and because it had several donors, international donors, the government of India, the Indian states, special TB allotments, and also money put into the general health services. But I think it's fair to say that during the 1960s, interest in TB suffered compared to malaria, which received more funding, and particularly compared to family planning. I think that the interest of the government of India changed in the 1960s, and family planning took away a lot of the funding. But it's a little shaky calculation, this one, so it's just a rough indication. Patient regularity, I already talked about that. Unsurprisingly, it was low. They were able to build a model program in a district in Andhra Pradesh in the 1960s where you could have 50% of the patients actually completing the treatment, the 12-month treatment. But when you looked at field conditions in the 1960s, it was 30%, and if you move up to numbers taken from the 1980s, it was 27%. So it was only a third of the patients actually in the program that completed the treatment. That, of course, gave rise to resistance. But one of the things that surprised me most while I was doing research for this project was the lax and relaxed attitude towards resistance. Among both Indian and global health experts, especially in the early 1970s. They knew that there was resistance out there, but they basically said it's not a big problem. Something which can be difficult to understand today, where we're talking a lot about MDR, multi-drug resistant TB. An article from 1953 written by 3 of India's leading TB experts says that pre-treatment resistance, that is the fact that you get infected with TB bacteria that were already resistant to typically to isoniazid, of which so much is being made these days, was not an important factor in treatment failure. And the WHO said the same thing. The expert committee at its meeting in 1974 said that the committee emphasized that the importance of initial drug resistance, that's again pre-treatment resistance, as a cause of treatment failure has been much overrated. So it seems that they knew about resistance, but they decided that resistance was not going to be a problem. Then there's a story, which I think I'll just skip because time is running, that the BCG vaccine turned out not to be very effective. And they realized that in a major trial in Chinglaput outside Chennai in 1978, and it was really a shock, and I have written about that if you want to learn more about that. But that's just another part of the sort of the problems that the NTP ran into in the 1970s. Then the program started to become reviewed because people noticed that it was not performing as well as expected. And the first review was done by the Indian Council of Medical Research in 1975. It says there's not enough supervision and control within the program. Case finding, as I have shown, was nominal, much too low. The equipment did often not work. Failures at the PHI level, the peripheral health institutions, they were not finding the number of cases, especially in the periphery, that they were supposed to. There was a need for more central control, a need for more specialized staff. But importantly, the conclusion was the structure, the idea of the program was fine. The problems were all because the ideas were not carried out in the proper way. In 1988, a local NGO in Bangalore also made a review saying many of the same things. Case finding, the rate of case finding is far too low. Low treatment completion, patient regularity, that's where we have the about 30%, only a third of the patients on treatment actually finished that treatment. Over reliance on x-rays. I mean, the idea was use the cheap technology, use the reliable technology. WHO decided in 1974 that the only reliable way to diagnose a TB case was through microscopy. X-ray diagnosis would be unreliable. This NGO estimated in 1988 that 500,000 people were wrongly diagnosed with TB and wrongly given antibiotic drugs. It cost 90 million rupees to give out these drugs for people who did not suffer from TB because they used X-ray to diagnose them. Lack of integration. If you look at the peripheral health institutions, they said that 50% of the people manning these peripheral health institutions, they would not be highly qualified doctors. They would be what is called here multi-purpose health workers. And half of them, this report said, can't even diagnose a TB case. They don't know how to make a diagnosis. So that was also a problem. And then they also said that there's a lack of attention from higher authorities. People that were interviewed working in the TB program, they said, we feel that the government is neglecting us, that the government is much more interested in malaria or in family planning. We feel that we're just, left to ourselves. It was a very critical report, but still the main conclusion was it was basically a sound program. The principles, the structure of the program was all right. 4 years later came a CEDA WHO review, which again says NTP functioned far below its potential. The number of cases diagnosed through microscopy were extremely low. Again, for some reason, TB workers preferred X-ray as the tool of diagnosis. Drug resistance is a significant problem. This is the first time I see in official publications relating to the Indian TB program that resistance is a major problem. 1992. The cure rate is not monitored. The thing is that the program was not following up on patients to see if they were actually cured. They just kept a record of how many do we put in treatment, how many completed the treatment, but not how many were cured. I'm finished in one moment. And no evidence, they said, of a significant decrease of TB in the last 3 decades. They could follow all the surveys that had been made. The level of TB in India in the early 1990s was 400 sputum-positive patients per 100,000 people, or the same as it had been in 1960 when the program started, or roughly the same as it was in Britain in 1900. So that was after 30 years, you could not see an effect of the TB program, but you have to say that you don't know what the picture would have been if you had not had a program. There might have been even more TB. But the National TB program was not able to reduce the TB rate in India. It was able to make it stable. This report gave rise to a thorough it recommended a revitalization of the program through political commitment, initial investment, and strong leadership. And in 1993, the program was revised, and the government of India introduced the revised National TB Control Program, which was based on the DOTS strategy, which was different in many ways from what I have outlined here, and I don't have time to talk about that, but that was sort of the end of the Indian National TB Program. Very briefly, the ideology behind the NTP, I think I can quote Stig Andersen, this medical officer, who in 1963 wrote that the government of India had formally adopted the policy that the prevention and treatment of tuberculosis is the task of all general public health services, and that tuberculosis control in India shall be developed not as a specialized service dedicated to a fortunate few who live near TB clinics, but in consonance with, indeed, as part of the expansion and improvement of the basic rural and urban health services. I think that expresses the ideology invested in the NTP quite well. And you can also say that it was based on the ideal of integration. You could also call that a holistic approach. There was a sociological element. There was a wish, a desire to incorporate the patient perspective. You could call that perhaps community participation. And then there was this idea of using the appropriate technology, which would be here typically use the microscope, the reliable and cheap microscope, rather than the expensive, unreliable X-ray machine that often breaks down in an Indian district. Right? So that would be the appropriate technology. These, of course, are the 3 principles I see as the pillars of primary health care. So I think that the Indian TB program, as it was designed in the 1960s, was also an early example of what lived on in the primary health care approach. There are some continuities there which I find interesting. And then, of course, we have to look at, we are historians, we have to be critical, we have to see why did the NTP not perform better? Why was it not a smashing success, despite many of the very good intentions invested in it? Of course, lack of resources is one thing. You know, I think TB control is costly, and if you try to do it cheaply, it is always going to be difficult. I have been surprised by the fact that drug resistance was, if not ignored, then certainly played down. Of course, I see that with the benefit of hindsight. I know that drug resistance is a major problem in TB control today. But I'm so desperate when I read it in the sources. I think, oh, come on, resistance is not a very big problem. We'll just continue using a one-drug therapy because that's all we can afford. Maybe it was very difficult. It was very difficult choices to take for people. Should we give this one drug to this patient and risk the creation of resistance, or should we give this person no drug and leave this patient to die? This is a dilemma. So it's not an easy one. Still, I think at the expert level, the way they did not take resistance serious surprised me. There was, of course, the prolonged fate in the BCG vaccine. They continued to invest a lot of money in the BCG vaccine, even though they knew that they did not know if the vaccine was effective. And when they realized that it was probably not very effective, that was a big problem. Too much faith in the patient. I think that although you would like to empower the patients, you would like to see patients as resources, I think, again, with the benefit of hindsight, that saying that the patient is this self-reporting subject that comes up to the TB services and asks for help and then faithfully and rationally takes the drugs for 12 months, maybe that was problematic. And that is, of course, also one of the things that changed in the DOTS program, where you have this idea of observed therapy, that someone actually watches while you're taking your medicine. But that, it can be debated, but maybe I think that this program did put too much faith in the patient. Lack of supervision, I mean not here supervision of the patient, but lack of supervision of the different levels within the program. And maybe also too much faith in abstract planning. I mean, I was surprised to see how you can make a review of the NTP over 15, or make 3 reviews of the NTP over 30 years, or over 15 years, and point to a lot of things that didn't work, and still conclude that the basic structure is fine. You know, maybe this would be more self-critical there. Yes. But that was my point. That was my introduction to my story of the Indian National Tuberculosis Programme. Thank you very much.
Good afternoon, everybody. Are we there, or are we on the phones? Good. I'm going to take you through a very packed couple of 30 minutes. I hope you're all awake at the end of it. Niels focused on one subject here, TB. I'm going to take you a little bit on the bigger picture and then focus also on the smaller picture. And I think one point he mentioned, has the TB program in India changed still now? That's something which we would like to do. And I said, Niels, we need to take the history a little bit the last 15 years. And not only the India TB program, but also the WHO TB program. I would show the relationship here and the importance there. First, a thank you to Sanjoy and Alex and Joa and Helen for starting me on this interesting path. Normally, I am a clinician or a public health physician, but I have started on this path of also looking at the historical aspect of diseases. I'm not sure if any of you here are a public health worker or a clinician yourself. Oh, wow, I'm happy. 3. Great. Okay. So I'm now taking another angle, and I would like to thank my colleagues here for giving me this opportunity. You would have heard from Niels the contradictions and the paradoxes in delivering services to people, whether it's TB, a disease, or health for all. So that's what. And again, I'm taking you a little back over 70 years. Like the UK Health Service, WHO is also 70 years. Anybody else 70 years? The World Council of Churches is 70 years. The Human Declaration of Human Rights is also 70 years. It's a very interesting disease. I'll go through this my presentation through this aspect of just looking at WHO, some of the old and new diseases, and also finally ending up a bit where we are. Do I have to point somewhere? Oops. Right. If you take this, you can forget the rest. Are we taking it? I am hoping we'll engage in a new phase of global health histories. It's been an interesting history. I was with one of my colleagues, old colleagues in WHO, Human, which Sanjoy introduced me. He was giving me a little bit of history of histories. But I hope we'll go for a new phase. And the most important thing here is engaging WHO and other public health leaders in the historical journey. And I'm one of those who have started engaging. I hope others. Many of you have followed WHO's Transforming, and also maybe a new global health architecture evolving. And one of the points is sometimes everybody focuses on the drugs and the vaccines, the new technology. I've been trying to convince Gates that's not all, but he has an American culture, and he thinks that will solve the problem. Unlike the Rockefeller Foundation in the past, it's the delivery structures and systems, as you have heard, and they are tough. The drugs are easy, the vaccines are easy. The people are the most difficult, and structures. And there are certain standards of public health programs and national health services, and you'll be surprised that these standards are not maintained. and then we expect results. And the question of balancing public health programs and national health service, the balance between vertical and horizontal. And the fundamental mistakes have been there before and continue to be there in different situations. The magic 70 years. I also want to emphasize medicine and public health is an art as well as a science. Sometimes our practitioners think it's a science and it works in a very logical way. Even science is also value-driven. And there are other issues between the issue of individual and social values and principles, the role of the state, and the balance of the market and the individual. And then there's the epidemiological trends and also historical trends. And that's why with Sanjoy now we talk about the issue of living global public health. Let's not also look very far back, but let's also document as we go along. So that's a concept we are also working upon. This is the methods I've used to provide some of the information you'll see. Basically the publications of WHO. The records of WHO are very rich. And I have to really thank my colleagues in the library and archives and the photographs, which allows us to extract some of these so that one can actually make a picture of the past and the current and the future. It's not easy. And the value of archives is very critical in the library. And I have discovered this in this journey as we go forward. One of the problems we have is definitions, glossary, and terminology. 18th century, 19th century, diseases. In the 18th century, more fear and panic and hysteria, the plagues, the choleras, malarias, everybody didn't know what it was, where it was coming from, and how to respond to it. The 19th century brought in a little bit more confidence. And it also built in, after the World War II, and I and II, the importance of peace and working together. But as we went into the 20th century, we began to talk about health services. We got fatigued. And we talked about primary health care. And then today, we are in the current situation. Are we together? Hello? You follow the trends? Definitions are important, because if you are not clear about the definitions, what you are doing also becomes very difficult. Going back to the international sanitary conferences, before WHO in 1851, the biggest cholera outbreak in Europe, that started the work on international health. Cholera came into Europe. Before that was plague. That's, again, you can go back to that. This shook up the foundations of Europe. But also, as I said, then regular conferences. Then also the discovery, as you can see with Koch and Passini, the bacillus of cholera. And then you come to Yersin with bubonic plague. And then you come to the formation of the PAHO, or in the Americas, the International Sanitary Bureau. What comes out here is Europe had a focus, but also in the Americas there was another focus as well. And then you had the creation of the Office of International Hygiene in Paris, which was before WHO. So this is a little bit of a quick history of how diseases affect organization, international cooperation. That's how it started. It's not health services. And cholera was a very powerful voice. Very, very powerful. And then, as I think most of you working in the history field will also know the phases of history, and these phases have had an impact on global public health. Emphasis today, how history repeats itself, refugees and reconstruction. Today we have the same situation. We actually have quite a World War III, as you might see, what's been happening over the last 15, 20 years in the Middle East, in Iraq, Syria, Afghanistan, and Yemen, and also many parts of Africa, South Sudan, DRC. But in those days, when you record the World War, it was Eurocentric. But today, we really have a World War as well. But nobody wants to look at it that way. It also depends on your perceptions. But again, independence, many countries in Africa and Asia, the new nation states, 1948 to 1980, had a lot of effect on how you delivered services. Many countries were very enthusiastic, moved very fast during the first 10 years of independence, and then right now, things are worse than they were post-independence. WHO has a role. This is its goals. It has been built on the issue of social conscience, joint international action, but critical is the neutrality. And that has sometimes been jeopardized, as it was from 1948 to the first 30 years of WHO. And if you look at the history of WHO, the current 40 years, it's a little bit unclear. And that comes back to the importance of looking at the historical trends and the various. The other issue is the principles of WHO, relates to the UN Charter. Health and the definition is very critical. It's not only physical health, but also mental, social. What was missing is spiritual and happiness, which is now being included in the well-being. And then there are other aspects of it. These are the basic principles. And one of the 2 points I want to emphasize here, which are marked in red, is coordinating international health, stimulating work on eradicating epidemic, endemic, and other diseases. As you can see, the contradiction between the goals of overall health and also focus on diseases. This is important because these don't necessarily contradict each other unless you interpret it in that way. So people can interpret it within WHO, outside, which ones to focus, which ones not to focus. And that affects the consistency of disease programs and also consistency, which I'm coming to, on health services. This is the other part. I wouldn't spend too much time. Now, WHO works in this way. It's a bit of a complex system, but one of its core was its expert panels and its expert network of experts. And I think the point which was mentioned by Niels as well, the TB expert committees. But when you look at the trends of these management of these committees and how WHO has functioned over the last 30 years, you might see a historical change in some of these. And I think one of the key aspects, again, Niels, WHO worked with countries to develop pilot projects which were expanded gradually and helped to move the programs of disease control or health service delivery. Am I going too fast? Are we together? Good. Now, again, phases of WHO in service to world health. When you look at the world health, if you look at some of the records, in 1948, there was actually fear of atomic war after the use of the atomic bomb. And that fear of the nuclear is still there. And then in 1946, WHO Interim Commission was set up, but many of the states wouldn't ratify. It only took a major cholera outbreak in Egypt to make things happen. So the formation of WHO was pushed by that. At the same time, there was also the refugees after World War II and the need for support. And that's when then WHO started focusing. And the first 20 years or so, its main focus was diseases. Yours, has anybody heard about yours? Heard and forgotten. Malaria, of course, refuses to go away. Tuberculosis, and then smallpox. Any of you remember smallpox? And it took a number of states. Initially, it was a few states, but today WHO has about 194 members. And one of its successes was, the smallpox eradication. But before that was the primary health care, which was one of the key aspects, which was 1978 to 1987. So you could see the disease control phase, then the health service phase, and then back again to the disease control, because the diseases don't go away and the need to balance these two. Recently I was in Holland, and the TB specialist services are still there. I don't know about Denmark, but the specialist services are there, and I'll come back to you again. Then the other critical element is the leadership of WHO and the health heroes. The first was from Canada, and then was from Brazil, and then the greatest hero WHO has had, who took it to highest level, was Halfdan Mahler. But again, history, different people interpret the story in a different way, but the facts still remain. Now, what are the interventions and tools? In the early days, it was only isolation and quarantine. But many of you remember, and burial. Ebola has reminded us that still is there. The panic, the fear, the isolation. And then the hygiene and sanitation. Today, cholera outbreaks in Africa, still there. In many parts of Asia, it's endemic. People forget about it, but it's there. So it started with what you call a cordon sanitaire, international sanitary regulations. Then came the microscopes, the public health chemicals like DDT, chloride, vaccines, and drugs. And then as the international health regulations went on, a combination of drugs, not single drug, then combination of drug. And today we talking about new vaccines, new drugs, new diagnostics, new insecticides. This is the other element which happened. While we're dealing with the diseases, the issue of dispensaries, hospitals, health service, health insurance. Again, this has also gone at different points in time. In the field, military health services, mass campaigns, the mission health services, strengthening health systems, the 1970s, primary health care, and then now we are in health insurance-driven health services or national health services. A unique one is here in the UK, but you go across to the US or some parts of the continent, it's health insurance driven. Are we together? So these are some of the trends which go. Whatever I mentioned before, the building blocks of a good program in the health system, these are essential. But somehow people still forget the standards. People think a vaccine will deliver itself, a new drug will deliver itself. And then they are surprised they don't get the impact. So this is still, lessons from history are being forgotten. And this is why the history is important. So that's a success. But the success of smallpox was not the vaccination. It's the active case searches. People didn't wait for patients. They went looking for them. They went looking for. So the field work, those Land Rovers, very critical. Those field people, the health workers in the field workers, was very critical to make smallpox. Now that was made a success between 1966 and 1980. That's what set up the global immunization program. Today, some people refuse measles vaccine. Now we're including new vaccines as well. This is the basis which started it all, the smallpox vaccination. And you all know the history of the smallpox. Now, this is where we are worried. The global polio eradication, launched in 1988 to end polio in 2000, based on the success. Halfdan Mahler wasn't sure about it. He didn't like vertical programs. But in spite of that, he was a pragmatic man. He allowed a lot of things to happen. He was not a dictator. Even if he didn't agree, he will also go. So that was a very important point of that leadership there. But up to now, with a lot of financing, we have still not finished the job of polio. As you can see, in 2017, we are still in a few countries. We're getting there. There's a few cases, but it's still not finished, and it needs to be finished. How am I doing for time? 25 minutes. Oh, I'm doing well.
I've done 5 more to go.
Now, this one, I don't want to spend much time on it, the tuberculosis control. I think you've heard from that. But one of the things which we have is the historical links with Scandinavia, the historical links with WHO, the use of vaccination at that time, the BC vaccination, the different ways of delivering it. But this was the problem. and it still remains a problem. Integration or a specialist program. Neither nor is the most dangerous situation. Lots of money wasted with no results. So this is 1964, they were struggling over this issue. And in 1973, they were still struggling over this issue. And the funniest thing is, if you see in red, how do you deliver when the infrastructure is weak without a vertical program? So the necessity of either or has been a challenge. And the same thing with the malaria eradication program. 1954, by 1969, it had achieved a lot. But however, today we are still at the crossroads of trying to deliver on this program, which achieved a lot by 1969, but was not able to continue for various reasons. Drug resistance was run, but the biggest problem was resistance is not just biological, it's human resistance. People get fatigued. A good disease control program is time limited. If you go beyond 15 years, you miss the target. The organization, the structures. So sometimes people continue to focus on the disease, and I'm sorry, it's more than the disease, it's the human being who manages and runs the program and organizes the program. And you always hear the word political commitment, extra resources, extra resources. This is an unfinished business, yours. It was successful, benzene, with penicillin, and then when it came very low, we just gave up and forgot about it. And we are trying to finish the job now. Is it lack of resources or political will, or is it professional will and WHO sustainability? This is another thing. Started in the 1981. The job is still not done. We're almost there. Guinea worm. Thanks to President Carter, there was a big push on it and got momentum, and it's almost there now. Today we have new and old diseases. HIV. We never learned the lessons from leprosy and TB, the stigma, the discrimination, the lack of drugs. We just never did. How? Why? And then today we are repeating the problems of Zika with malaria and dengue, the lessons learned there. And today we have also the problem of cholera. And then on top of that, we're now focusing on non-communicable diseases, but as far as 60s and 70s, WHO was talking about non-communicable diseases, but could not get a program in place. And still struggling to get a program in place. And then the question of National Health Service or National Health Insurance. Back to the future. Eradication was at one time a dirty word. Today is used liberally. Thanks to Gates, who believes he can eradicate malaria by 2040, as long as there's new tools. So you see that history is repeating itself. And today, everybody is going around saying we're going to end TB, end HIV by 2030. Of course, some of us might not be around, but is that the way to do it? Conclusion. There is a need to balance these things. It's not one way or the other, and that's very clear. But this new DG, which we have now, the first DG from Africa in 70 years, elected by all member states. Before it was only by few, but he has to deliver on the diseases, and he has to also deliver on the health systems. It's a hard task. And he might have to put TB and HIV back on track, especially TB. And then, of course, deliver on. But we have lessons, and this is why what we are doing, as I said in the beginning, is with Sanjay and others, is work in progress. Could be valuable, but the problem is, can the public health workers learn from history? Can we engage them, teach them the methods, and work together with them so that they will see the valuable lessons? Already when I listened to Niels today, the district TB program, You can never achieve anything without a district focus, whether it's a district health system or a district TB program or district HIV program or malaria. And so my main message comes back to is the importance of vertical and horizontal, but more important is the magic bullet is not there. It's the structures and the systems and the people. Thank you.
Okay, till the audience takes some time, I have a few questions. First to Niels. I was struck by this assumption of the program, the NTP, that the word that was used, passive.
Mm-hmm.
So how was the communication model then? I mean, if patients had to come and seek services, how did they know that services existed in a primarily non-literate kind of a society? Anything fascinating that you found over there?
No, that's a very good question, and I'm not really able to answer it. I think that there was definitely some kind of peer going on saying, listen, we have the general health services, you have to go to see the doctor at your nearest health institution, center, which would be the health center in the village or in nearby village or somewhere else. But I think that the general observation was that, and also what the people admitted in their reports was that there's no point in going out identifying more patients because we do not have the resources to treat more patients than those already aware that they can seek assistance from us. So it was said more or less in these words that, you know, why invite more patients in when we can hardly treat those that come on their own?
But wasn't that self-defeating? Because
but what would you? I will not. I don't have a strong opinion whether this was right or wrong, really, because I think that what would happen if many people turned up? You spend resources on getting more people to turn up and say, yes, you have TB, but we can't help you.
okay.
That I guess was the calculation. But I also think, and that's something that I have come to think of lately, that when I speak to some of the people involved in the program, some of them would say today that it was not really about controlling TB as such or ending TB, as you said in the end. It was perhaps more a program that should relieve suffering. So if existing patients and patients that felt, they used this word, felt need. You know, if people felt that they needed to go to get anti-TB treatment, we should offer it to them. But that would be the basic philosophy, because they would say, we are realistic. What can we do?
I have one more question, and this comes out of. Are there any questions? I'm sorry.
No,
Okay, you can.
I just the idea of the World War III, which is going on, as you said, in the Middle East and Africa, and if you compare the diseases which were in World War I and II to what is going on now, is it comparable in terms of what type of disease were there and how were the control measures at that time was implemented by the World War II and III, and you said there's not undeclared war going on. What's the definition of World War to define as this is international rather than local, regional?
I use that to bring home the fact, and this is what the new WHO strategic plan focuses on. It focuses on 3 billion target. One is people living in emergency situations, which is conflict situations. Yemen is a good example, where you have seen cholera, you have seen diphtheria. Go to DRC, where you have seen yellow fever, and you have seen cholera and Ebola. The response has to take that thinking in mind, and the current WHO has put that thinking in place, although it hasn't declared a World War III because it cannot do that. So that's one example.
If I can just add, I think the striking thing in what you're saying, by talking about World War III is that the diseases that are coming up in refugee camps and in connection with the wars which are going on in the Middle East or in Africa, they're depressingly familiar. It's cholera, it's dysentery, it's diarrhea, it's all these diseases that would have been there during the First World War or even wars in the 19th century. So I think that it is not new diseases; it's the same diseases that comes again and again.
Sorry, there was somebody there.
Yes, please.
Thank you for both presenters. It was really fascinating. And for me, it's really, I have one comment about the TB control during 1960s, and I just want to give a little bit of the Sri Lankan experience. Sri Lanka is a country very close to India. And in 1966, there was a project called Northwestern Province TB Control Project. It was initiated with the support of WHO and the funding of UNICEF. And initially it was a really a good one, where it is similar to Indian structure, where the periphery was strengthened to make decision on patient management and the diagnosis of the active patients. And but ultimately, after 3-4 years' time, it was not that much success, since the particular project has not identified the demand from the supply side. The first one was people from the villages. They didn't want to go to the peripheral clinic due to stigma. Therefore, they always seek medication from the center. The center was overcrowded and the periphery was really underutilized. That was the first the failure. The second one, the infrastructure was not that sufficient to carry out a proper pilot project. And thirdly, the staff. The staff was really not that much geared to cater in that big, since the TB treatment is sometimes a face-to-face treatment. Because of the infectivity, staff is not that much associated with the patient and the periphery. Thirdly, the funding support from the UNICEF was not sufficient, especially the vehicles. Therefore, the position was not that. Therefore, it has been a total failure. But thereafter, I can see there are good initiatives from the other side of the country as well with this experience. My question from me is really, it's the resistance, special drug resistance, has been identified during that time, especially the pan-drug resistance. Now it has come to the multi-drug resistance as well. And the measures taken at that time was not sufficient in terms of financing to supply of inhaler. The current drug treatment of IMH, bisphenolamide, ethambutol, and the rifampicin was not in that era. But the IMA, which is a sufficient drug, but it is not complemented with the second drug. What do you think that the financing from the funder or the national government was not sufficient due to what type of reasons? Whether it's they could have identified in advance, whether they have really did the root causes for the particular initiation of the drug resistance at that point. That's my first question. The second one is from the WHO perspective, and I have seen many initiatives started from the WHO side was really successful. Meantime, there are some unsuccessful measurements and initiatives also. And the reason one may be the Ebola. I mean, maybe this critic says it's success, then some people say it's not success. I would like to know how WHO really work with the other nations, especially developing nations, in terms of strategizing interventions, in terms of identifying the people needing or analyzing the country social, political and economical situation, or whether it's a one-way course.
Thank you.
Yes.
Yeah, I think that first, I mean, I think the root cause of resistance, I think whether it was economic, yes, I think it was a problem of not being able to buy enough drugs. And you can say that yes, UNICEF and WHO did not, especially UNICEF, who would normally be the organization that gave most money, most funding, should have supported the program more than they did. The idea was, of course, that the government of India should bear the cost of the drugs over time. That should be the government of India who did that. But I think that there are also more than pure economic reasons into the equation, because I think that it's also a question of logistics, that, you know, getting the drugs out where they were needed, and also I think that India, of course, in this period had an ideology of self-sufficiency. So it was also an issue of being able to produce the drugs they needed in the country. And I think that was part of it, was that the Indian production facilities, the pharmaceutical plants in India were not, did not have the capacity, and therefore you had to ask for external supply. So I think you can always say that, and that is of course always true, but it's also always very easy to say that if we only had more money, we would have solved the problem. But you know, where would the money come from? Yes, you can say, you can of course say, yes, we should spend more money on health. We can all agree on that. But it's not really an answer, I think, to a historical analysis. And the other question, if I understand it correctly, is, you know, whether it is successful or not. I think it is what is the measurement, because you can say that, well, the National TB program in India was very successful because the level of TB didn't grow. It was kept down at the level it had around 1960. That was successful. You can also say, no, that was not what they had hoped to do. They had hoped to reduce the rate. And they're not very clear on that. I mean, no one is saying that, okay, we are going to eradicate TB. No one in the Indian program believes that. But what you can see is that as the reviews that I went through in my presentation, they indicate that people feel that something is not as good as it should be in the National TB program. And I think that is something that comes in the sources from the late 1960s and in the 1970s, that we are not quite happy with the performance. And I think that what would be wonderful would be if you could make, if you could find numbers and statistics for China. And of course, also knowing what did they do in China to control TB, and if you could compare India and China, you would have some way of measuring whether we should call the National TB program in India successful or not successful. Because yes, what is a success? I mean, but my presentation is clearly based on the assumption that the National TB program was, as we moved into the 1970s, a disappointment.
Ben.
Yeah, hi, thanks, both great presentations. I've got a question for both of you. The first for Niels. You were saying that the National TB program probably caused stabilisation rather than any decreases. Do you know of any data or any work with comparative examples where you could assess whether there was actually a considerable impact or whether actually there wasn't? I wonder if between the regions you might be able to figure some of that out. And also I was wondering, just a small question, with the X-rays, do you think it's because locally they were interested in looking modern? Do you think it was a part of their own pride and, you know, they were able to control this piece of technology rather than doing the thing that actually they were maybe supposed to? And then for Shiva, the question I had was, you were talking about the malaria eradication program, the first in the 50s. One of the problems with that seems to be that the focus on technologies like DDT rather than solving long-term environmental problems like clearing drains and stuff like that. I wonder, what do you think are the key lessons that have been learned that wouldn't be done in the same way in the malaria eradication in the next 10 years?
Do you think we should take the last question?
We can take the last question
Yeah.
and we can wrap up, yes.
Can we take the last question because Niels has a train to catch.
Congratulations for both of you. My name is Carlos Campani and I'm a Brazilian physician. My question is about a vertical versus horizontal approach. Historically, there have been lots of discussions as both of approach cannot coexist, despite the fact that both approaches already demonstrated successful experience and failure as well. So why do you think that we are meant to understand that both approaches cannot exist? Why there cannot be a balance? And how we as future public health leaders can avoid this trap to have political will or political commitment and not be just simply visualized as horizontal or vertical approach. How can we avoid this trap?
Thank you.
That's exactly the most critical thing over the next 10 years or next history of health, especially in Africa, is going to be how to balance those two. If they don't get it right, it won't. Then I'll use Brazil as an example, where the whole area of control of both malaria was initially achieved without DDT or IRS, but larval and environmental. The same thing with Cuba, but they pushed very hard. Then they added on the IRS and DDT, and then the new drugs. And the lessons of the malaria eradication program, even today, is, and for all programs, is never use one tool alone. In the name of cost effectiveness, have an integrated multi-approach. And unfortunately we haven't. Today, everybody will tell you, if you give people mosquito nets, your malaria problem is solved. So we have a problem there. So an integrated approach to any disease control is important. And one of the most important things which fails, and I come back also on TB, is the people and the communities have to be mobilized. It's vital. And if they are mobilized, then, and any malaria program, I think, or any primary health care program, or any health service, which depends on people coming to a clinic or coming to a center, fails. You have to go to the people, be with the people, screen the people, educate the people, then your TB problem is under control. The same thing with malaria and many other infectious diseases. That fundamental thing, people somehow lose it, that you can't treat in clinics and hospitals. And so, and coming back again to the issue of TB is, coming back from smallpox and other areas, leprosy, you have to do active case finding. And this fundamental problem which we have we've seen this over many years and still continue to say we will treat passively and we're not going to reduce the infection. Because infection control is interrupting transmission, not just managing the disease. And that fundamental problem is there. So, so answering your point, answering the unfinished business of malaria, coming back to also the unfinished business of TB, the last executive director of the Global Fund, where we have a lot of money put forward, sort of summarized that. With all that money, we still haven't moved. So there is still a design delivery problem. But people will say, no, we need new drugs, new diagnostics, etc. Coming back to the last point, WHO's failure, rise and fall of WHO. This is why in the history you can see WHO did well, and Sanjoy would also look at it, and I hope all of us are going to study this. The first 30 years of WHO was a success. But the last 40 years of WHO has been lost in many things. And the biggest shock for WHO was Ebola, and the first failure of Ebola. Currently, the WHO is focusing on Ebola and trying to get it right. So that's something which is a good point which you make. The other failure of WHO was cholera, unfinished business. It's not that it's become worse in Yemen or in Tanzania or Uganda. There has been outbreaks going on. It's only the last 2 years WHO has begun to start moving, especially this year. So there is the failure of WHO. The success of WHO is malaria elimination in Sri Lanka. In spite of the war and everything, it managed to push forward and get it done. So that's one of the good examples. But the failure of WHO might be TB. We must ask more questions on this one.
I think I can give 3 very brief answers to the 3 questions. I mean, I think I agree with you that it's a trap to think that you have to be either horizontal or vertical, and that there are no, I mean, I would be very pragmatic on this, and I think that a mix would, the problem is, as you say, what is the right mix? But in principle, I agree with you. For your questions, yes, I think we should do some comparison. I don't know of any comparative studies. I haven't done them myself, but they should be done because that would give us a fairer assessment of the Indian program. But again, it is clear that India is sort of they're dragging their feet going into the DOTS area because they were happy with their program, whereas the rest of the world say, no, your program is not performing well enough. You are sort of falling behind. So I think there was a sense that we have a better design now with the DOTS program. Whether they are actually better, I think it still remains to be seen, because they also produce resistance, and they produce not resistance but multi-drug resistance because they have more complicated treatments and so on. So I mean, we'll wait for the DOTS era to become history before we can say that. And the final thing, yes, I think they wanted to be modern. That's why they preferred the X-rays, because they wanted the most sophisticated technology. There was prestige in using the X-ray machine rather than the microscope. I agree with that totally.
Can I make a very quick comment? So is it, but even now, the first thing is the X-ray, isn't it?
No. The first thing is the microscopy.
But I was not assessed like that.
No. But what does that tell you?
Exactly.
So because before coming to the UK, I was mandatory to do a TB test.
Mhm.
So the thing that they did was an X-ray.
Mhm.
And this is in the UK visa certified center. So I don't know, I'm quite...
Yeah.
And then that scared me, saying that if there's something problematic, then we'll do a sputum test.
Mhm.
And I was just praying there shouldn't be a
Yeah.
sputum test. So
I think you can do it the other way around, but you could also just do the sputum test and not do the X-ray.
yeah, so this is...
I will add a little bit on that. Until 2016, it was really sputum-based test for the UK immigrants, but anyway, they have changed into
Okay.
X-ray.
Mm.
Saying due to it's very much convenient. You can
Yeah.
get the test or whatever on the
Mm.
same day, but
Yes.
that's not the ideal thing. But in Indian setup, but I really think some doctors are very much keen on diagnosing that intuition. They know that last year I was in Bangalore, the chest control disease center for Rajiv Gandhi Institution. There I met a lot of doctors. What they said, before doing all the investigation, they know that this patient has got TB or not in their experience. That's third world experience. We have millions and millions of
Yeah.
patients.
Yeah.
But the diagnosis from X-ray is really tricky in terms of differentiating from some forms of TB, especially now we don't treat, we treat only active TB, but latent TB also can be recognized as active TB. That is the biggest problem for the UK immigration system, where sometimes they ask us to treat latent TB to get what we call clearance from the TB test. And but if we going to treat latent TB in India, it's millions and millions. It is not effective.
Yeah.
Thank you. Thank you very much. It was a
Thank
very
you.
enriching experience. May I also request all of you to fill feedback forms for us? Thank you very much. Thank you.
Thank you.